Okay, I think we can get started now. Hello, everyone. Welcome to the Musella Foundation's Brain Tumor Webinar Series. Today's webinar is on GammaTile therapy with our special guest speaker, Dr. Ken Tatebe. Dr. Tatebe is a radiation oncologist and assistant professor of radiation oncology at Rush University Medical Center in Chicago. He received his Bachelor of Science in Physics from the University of Texas and his PhD in Physics from the University of California, followed by his medical doctorate from the University of Texas Southwestern. After completing his residency in radiation oncology at the University of Chicago, he did two externships in proton therapy and carbon ion therapy. Dr. Tatebe, we're glad to have you. Do you want to get started with your deck?
Sounds great. Thank you very much for that wonderful introduction. Let me share my screen with you, and we should be all set to go. All right. Can you see my screen, or presentation rather?
Yes, we can. Thanks.
Awesome. Okay. Well, thank you again, everyone, for inviting me, Dr. Musella and everybody else. I appreciate the opportunity to talk about what's become an exciting new technology in terms of brain treatments. So hopefully everyone is able to learn a little something. Already had the introduction. I work at Rush. We are an elite GammaTile center, which is the main mode of implanted surgically targeted radiation that I'll be talking about today. I do a few disclosures in terms of other consultations and collaborations I have with industry. So before I dive into the nitty-gritty of implanted radiation and surgically targeted radiation, let me back up a moment and talk briefly about standard radiation treatments and how those work with brain tumors. So many times brain tumors will be resected, but even with resection, a large portion of those tumors will ultimately get treated with radiation as well to help prevent recurrence of that tumor in the surgical bed. That course can often take several weeks from the time that a patient presents with symptoms. They get admitted, they get a resection, and then often it's a day or two of recovery in the hospital before discharge. Thereafter, they're seen again in the outpatient setting. They get new imaging, new MRI, perhaps a CT scan, and we see the new shape of the post-op cavity. We see whether that's shrunk or changed shape at all. And based on that imaging, we do radiation treatment planning for external beam radiation. So radiation given with a machine from the outside targeted to the tumor bed. That planning often takes 1 to 2 weeks. So ultimately, from the time of resection to the time of radiation treatment, there's anywhere from 2 to 4 weeks between surgery and radiation. The radiation itself, if it's a radiosurgical procedure, is often between 1 and 5 treatments, although other types of treatment can be longer, up to 6 weeks or longer for other modes of radiation. Of note, when you come in for this outpatient imaging, there is a lot to be done at that time, including, if any of you are familiar with radiation to the brain, this mask making that we have. I have here a video of my nurse getting one of these masks fitted to her just to get an experience of what that's like. This is sped up a little bit, so it's not always quite this frantic, but the mask is warm when it goes on, it's pliable, and it molds to the patient. When it cools, it becomes rigid, and this is what the patient wears for the external beam radiation. Needless to say, this can cause a bit of anxiety with patients, and it's maybe not an ideal method of immobilization, but it works well. Fortunately, the therapists were also kind enough to let me undergo a mask fitting just so I can get a better sense of what it's like and kind of get a better idea of the anxiety that causes our patients to better counsel them. In full disclosure, I've never had GammaTiles implanted yet, so I can't speak firsthand to that, but hopefully I can give a little bit of objective knowledge. So given that this is normally how radiation works, what's the difference of what we're talking about here? Well, GammaTile therapy is a surgically implanted radiation therapy. So this tile is a small square of collagen, similar to the collagen used for fine lines and wrinkles, for lip filling, and now also good for brain tumors. The tumor itself is embedded with 4 radioactive seeds, contains radioactive cesium, and these are placed in the resection cavity immediately after the tumor is removed. So the radiation starts working in the cavity as soon as they're implanted in the operating room, with no delay in time to follow up or planning or subsequent treatment. The real clever component of the GammaTile is the embedding in the tile itself. Brachytherapy, this implanted seed idea, is not new. This is a tried and true technology. It's still used in other tumors, for example, in prostate cancer or in cervical cancer. But the real trick is holding the seeds, these radioactive sources, at a precise distance from the brain and a precise distance from each other. And that's kind of complicated inside the brain cavity. And so embedding them in these tiles is an elegant solution to that. That seems almost obvious in retrospect. It makes you think, why didn't I think of that? But it really provides an excellent way of providing dose on tumor in an elegant way that's easy to implant and is very consistent. Well, at least I think, why did I think of that? I don't know if you guys think that, but all right, so how does this work? Like any other radiation, radiation is a tried and true technology, whether it's external or internal. The radiation itself will damage the DNA inside the cells of the tumor. And once that DNA is sufficiently damaged, the tumor is unable to replicate and eventually dies trying. As I said, the collagen tiles keep the sources in place and prevent them from moving from where they need to be and keep them in the correct proximity to the brain to make sure the brain gets the appropriate dose. As those decay within the first month or so, most of the dose is delivered, about 90% of it. And after a full 100 days, the tiles are considered inert, effectively with no residual radiation. The collagen is natural biologic type material. It is resorbed into the body. The seeds are not, but the seeds become inert and there's no need to go in surgically to take them out later. They just sit there, are inert, and it causes no further issue. So to get a better idea of how this is done, let me play a brief video. This is from the company itself, and to give you kind of an idea of what this looks like in terms of a procedure.
GammaTile is a surgically targeted radiation therapy for patients with operable brain tumors. GammaTile consists of a bioresorbable collagen tile that is embedded with 4 small radiation sources. After the tiles are placed, GammaTile therapy begins delivering a therapeutic dose of radiation to the target area, while protecting healthy brain tissue and minimizing radiation side effects. GammaTiles are placed into the operative bed, covering the tumor cavity with tiles. The number of tiles implanted is customized for each patient based on the size and location of the tumor. GammaTile immediately begins delivering a targeted therapeutic radiation dose to remaining tumor cells. The tile provides a structural offset of the sources from brain tissue, protecting healthy tissue from the side effects of radiation. The latest advancement in brain tumor treatment. GammaTile therapy is FDA cleared to treat patients with newly diagnosed malignant and recurrent brain tumors.
Okay, I'll stop it there. I have a little bit more to say about outcomes and quality of life later. So, but there are several videos online from GT Medical that you can look at your leisure to get more information. But for now, let me move on to the workflow that we have once you're in the hospital. So the tumor that has to be surgically resected, you go to the operating room, and the neurosurgeon will resect the tumor. After resection, immediately in the same operation, the gamma tiles are then placed in the surgical cavity, and the radiation, just by geometry, is focused right on the surgical site, right in front of the tiles. Because the tiles have a very short range of radiation, this helps to limit dose to the rest of the brain in a way that's not really feasible with conventional external beam radiation. With external, the dose necessarily has to travel through the head to get to the tumor site or the tumor bed. In this case, this radiation is starting at the tumor site or the tumor bed. So it can be much shorter range and expose a lot less brain tissue on its way out. In addition to limiting brain tissue exposure and the side effects associated with that, the skull is actually very good at shielding the radiation, and the dose to the scalp is actually very low as a result. This results in a nice perk of the treatment, which is it really minimizes other side effects like hair loss. Anyone who knows someone who's undergone radiosurgery to the brain or any sort of conventional radiation to the brain knows that hair loss is part and parcel with that and can often cause some undesirable cosmetic outcomes. So this really helps minimize that and speeds recovery from both the physical and psychological perspective. And because there's no need to return to the hospital for these treatment scans, for the treatment administrations themselves, GammaTile is working as soon as it's implanted, and these radiation seeds are treating the tumor when it's at its lowest burden, when it's immediately been resected. So that does aid in moving forward with your daily life. You do still have to return to the hospital for surveillance and other imaging, but you don't have to come back for the radiation treatment. So this can be very useful for patients that might find it difficult to return to the hospital in quick succession for radiation, and a couple other cases that I'll talk about in a few minutes. In general, this treatment has been shown to be rather effective and is very well tolerated. As I said, brachytherapy is not a new thing. This implanted seed idea has historically been used in many of the disease sites, including brain. The problem with brain is often they were implanted with seeds with relatively little infrastructure around them. As a result, the seeds gave a good dose to the tumor or the residual cavity, but there were a lot of hot spots that resulted in a lot of inflammation and necrosis. And in one study, over half of patients had to come back for reoperation, not because of recurrent tumor, but because of issues stemming from the radiation damaging brain tissue. By contrast, preliminary studies from the company GT Medical showed that control rates of metastases were quite excellent. And in fact, all tumors about an inch, about 2.5 centimeters, were controlled in a year after being implanted. Most importantly, it was very well tolerated. Only 8% of patients had any symptoms from radiation. A couple of us had some symptoms from the surgery itself, which is not unexpected. All the radiation issues were managed medically. None had to have reoperation. So that's really telling of the good dosimetry that we get from these tiles and the appropriate effects on the brain. This study was done through the company, and so of course we always want to see validation of that with other centers. So that's what we look for in the literature to convince ourselves that this is the right way to go. Memorial Sloan Kettering has published their experience. So these are 20 patients. They all had prior radiosurgery. So radiosurgery is a focused form of external beam radiation we give patients after surgery to prevent recurrence. So these patients all had surgery, all had radiation after, and all recurred despite the surgery and radiation. So these have already failed once. The recurrences were typically about 3 centimeters, so a little over an inch, and they were treated with re-resection and GammaTile placement. And they had over a 90% success rate. At a year, only 8% had recurrence in the cavity. And the symptom rate from the radiation was similarly low, about 16%, a bit higher than previous. But again, these are previously resected, previously radiated patients. So this is kind of a challenging cohort to begin with, and 16% is actually respectably in line with standard radiosurgery procedures. In addition, Miami has recently published their experience, again, with recurrent brain mets, all previously radiated, all about an inch in median size. And of note, the patients in this cohort, they were selected because they recurred. But what's interesting to note is when they recurred. They recurred between 6 and 18 months, with patients in this recurrent group, albeit, having only 25% of patients having control at 18 months. So these are already kind of tumors that are bad actors. They're recurring relatively quickly. They're getting radiation and growing despite that. These patients are resected for salvage. This is a re-resection, second surgery, followed by GammaTile placement. And these show excellent control with 100% control at 18 months. So this is better control even in the upfront, whereas typically what we see is salvage tends to do worse than upfront treatment. Once it's recurred and you've proven to have a tumor that's a little more resilient, it's harder to treat. But these have done very well, again, with a very reasonable rate of radiation necrosis. Again, all managed medically, no further operations necessary for managing any side effects. Also, is an interesting case from the University of Minnesota. This, I think, highlights another benefit of trying to implant radiation at the time of surgery. Here we're implanting right after the tumor is resected, when the burden of tumor is the lowest, right? After the resection, if there's any residual tumor, it's only going to grow from there. So there's only going to be more cells of cancer moving into the future. So this is the time at which we have the least burden of disease, and arguably, then theoretically, the highest efficacy of the treatment. In this case, they had a gentleman with metastatic lung cancer, so a lung tumor that had spread to the brain. You can see that tumor up here on the A row. After resection, the MRI in row B shows excellent resection, no obvious residual tumor, really good surgery. In spite of that, just a few weeks after resection, there was a symptomatic recurrence. So it not only came back on MRI, it was causing problems. You can see some of the dark discoloration around the tumor that's it's the result of the edema, the swelling. And so instead of starting from ground zero and re-resecting and trying to get him back in for external beam radiation in that 2 to 4 week timescale before he recurs, they instead elected to re-resect and place GammaTile. In this case, it was quite successful. In spite of recurring within about 3 weeks previously, he went 3 months with no further evidence of recurrence. So with really good tumor control, again, with minimal side effects. So I'm happy to say that we've used this for these indications as well. This good-looking gentleman in the top row, that's Dr. Munoz. He's our neurosurgeon that has done almost all of the implants, and then me as well, taking a photo opportunity after achieving our elite status with GT Medical. We've successfully implanted for a number of different indications, including metastases, malignant gliomas, some recurrent meningiomas, a couple other indications. In general, patients have tolerated this very well. We have had a few issues post-operatively, generally what you would expect after any craniotomy, any brain surgery, but no additional toxicities as far as we can tell from radiation so far. The control within the resection cavity has been very good, with excellent control in the implanted volume. We're currently writing this up, so I don't have any numbers yet, but we will be publishing on these experiences soon. We did have one patient with a recurrence just outside the cavity in an area that was not able to be accessed surgically. So that's not surprising, but we did have one area where that did happen. But in general, quite effective. We've been very happy with the results so far. In general, this has proven a very effective, convenient, and well-tolerated treatment. It really limits dose to the rest of the brain tissue. It limits dose to the scalp. You keep a full head of hair as long as you had one prior to treatment, really with good effect. Treatment starts immediately at the time of implant, which is on the day of the surgery when your tumor is resected. It eliminates the need to return for follow-up treatments. Of course, it doesn't eliminate the need to return for follow-up for surveillance, but you also get to dodge using the mask, which is a nice benefit sometimes. And also of note, like with radiosurgery and other procedures, implanted radiation is no different. It can be used with other therapies like chemotherapy, tumor treating fields, immunotherapy, and a host of others. So it's been really versatile in that sense. It's also important to note that, I talk about all these studies and these preliminary results, but this has been out for several years now. And this is not an experimental treatment. This is an FDA cleared, insurance approved treatment for anyone with newly diagnosed malignant tumors in the brain or any sort of recurrent neoplasms in the brain. It's covered by Medicare and most private insurance companies. Personally, we haven't had a lot of issue getting these covered by insurance. Any questions, there's a lot of resources online. GammaTile themselves have a lot of the cancer centers that are providing these services have it on their web pages. Our web page has information as well. And of course, your brain tumor treatment teams, if you're consulting with them, would be able to answer any further questions. If you're thinking about pursuing this or have someone in your life that you think might be worthwhile, it's important to consider who's a good candidate for this. Again, this does require surgery. So this needs to be someone who would have had to get surgical removal anyway. In general, we don't do surgery simply to implant the radiation. If it's that small or inaccessible, often we'll treat with radiation alone, with the external beam, using the mask. But for those who require resection, particularly in the recurrent setting, this is an excellent technology to have. Not only for the current indications with recurrent high-grade glioma and metastases, but in some circumstances, it may be appropriate for upfront newly diagnosed malignancies as well. In addition, several clinical trials are open, including trials opening at our institution and some nearby. So keep an eye out for those as well. A lot of patients are looking for clinical trial opportunities, and this is one avenue that you can pursue for that. Some considerations in looking at this kind of treatment are, again, you need to undergo surgery for this. So you need to be a candidate for surgery, to be able to undergo a craniotomy and the recovery afterwards. It's also important to note that although we find this a promising technology, a tried and true technology in terms of both using radiation and using implanted radiation, it doesn't remove the role for external beam radiation. That's still going to provide an excellent benefit to a lot of patients. But it does provide a valuable tool in how we deliver radiation. And in some circumstances, it may be the best way to deliver that radiation. So it's a nice tool to have in your arsenal when trying to treat and prevent recurrence. Of course, it goes without saying that surgery carries with it its own risks. There's always some possibility of surgical complication. That's no different here. It is, however, important to note that the addition of tiles doesn't result in any further recovery period after the craniotomy. So of course, you're still in the hospital and you have to recover from the surgery, but GammaTiles don't appear to extend that recovery period at all compared to patients undergoing surgery alone. Finally, there is some consideration of exposure to other people, those around you, your caregivers with radiation. But in general, like I said, this radiation is very short range and the skull stops the radiation quite effectively. That results in less hair loss and also means a very low dose to those around you. in general, the hospital finds people able to be discharged in terms of radiation level very quickly after craniotomy. But of course, they'll provide additional guidelines for how to manage that. So, given that a lot of patients are at least candidates for this, and I think it's an effective way of delivering radiation that gives us a new modality in addition to other modalities we have now, I think it's a good technology to explore and have available. I think that's shown easily by showing the number of centers that are now adopting this across the US, with over 100 different hospitals now implementing this technology. And GT reports that they've treated over 1,000 patients. So if anyone's interested, happy to have you check out our website or find a treatment center near you to see who's doing this and maybe get more information. But I think this is an exciting new technology that's really shown to be very effective in recent years, and I'm happy to be able to present some information on that. But as I said, I haven't had any firsthand experience having it implanted. So with that, I would like to give a shout out to one of the GammaTile patient navigators, Patty. I had the pleasure of meeting her a few days ago. She's a wonderful lady who was diagnosed with glioblastoma back in 2021. She did undergo standard treatment with radiation and chemotherapy, which I think did a good job. She did well. Unfortunately, her tumor did return afterwards, and she ended up undergoing a second resection with GammaTile implantation. So hopefully she'll be able to tell us a little bit more about her experiences with that. If you'd like to speak to a patient navigator, there's some contact information below. And with that, I will hand off the presentation. Thank you so much for your time and attention.
Thank you, Dr. Tatebe. Patty, whenever you're ready, you can go ahead.
Thank you, Dr. Tatebe. Hi, everyone. My name is Patty, and I'm 67. And on February 21st, in 2021, I was diagnosed with glioblastoma. I went to the ED, and the next day I had brain surgery. Dr. Rav Gandhi did a total resection in the temporal parietal area. While in the hospital, I was introduced to Dr. Sharif Mark Makar, who became my neuro-oncologist to navigate through my choices. My plan was SOCH, which is the standard of care, which consists of what Dr. Tatebe was saying, the radiation with Dr. Farzania, chemo with 12 rounds of Temodar, and I was mentholated. And then in April of 22, I had an MRI that showed enhancement in a spot, and the tumor board met and offered me GammaTile technology. Because of the aggressive nature of GBM, I jumped at the opportunity and said yes to surgery. Dr. Gandhi and Dr. Muhammadin teamed up and placed 4 tiles. At present, I am celebrating almost 3 years with no side effects. And the only thing that I use now is, if you can see, I have Optune. And that's my thing. I'm just very glad to be here to help everyone to make the choices.
Yeah, we're really glad that you're here too, and thank you for sharing. And Dr. Tatebe, if you're available to answer some questions, we had quite a few come in through the chat. So to start, can any neurosurgeon use GammaTiles, or do you have to go to certified centers? And what happens if my doctor hasn't used them before?
So anyone can ultimately use GammaTile. That said, you can't walk into any door and use it. It was actually quite an ordeal to get it instigated at our hospital. It has to go through a lot of approval processes. It's not something you go down to your corner store and order and bring in. So there has to be a lot of supply chain set up, some safety protocols with the radiation department. There are a couple of sort of preliminary implants where there's some supervision for what's going on with the implant. And after that goes smoothly a couple times, then things are ready for prime time and everything's able to go forward well. So yes, anywhere can do it if they so choose to. but it doesn't mean you can walk in anywhere and just have it done. So if it's something you're just wanting to know about, anyone may be able to provide some information, but if it's something you're looking to get as treatment, I would go to a center that's already established.
Okay, understood. And you said that GammaTile is approved at the newly diagnosed stage as well as at the recurrent stage. So I guess how many patients are really using it this way, you know, as an alternative to standard external beam radiation?
I would say most centers, including us, tend to use it in the recurrent setting where you've had standard of care treatment that has for some reason failed, and now you're looking at trying to do something different, either because you feel like it might be more effective or because it might be lower toxicity. Some centers are using it up front. I think that's probably less common. In general, my sense is supplanting standard of care rather than simply using a different salvage kind of asks that some of that technology be put under a clinical trial to see how it competes with standard of care. Is it effective? Certainly looks to be effective. Is it better than standard of care? I think that's the real question. And so there are clinical trials open looking largely at upfront treatment. We have one opening soon for upfront brain met resection, not recurrent brain metastases, but upfront. There are other trials open for glioblastoma treatment upfront. So I think it is possible, but I think my bias is that more largely is being done in the setting of clinical trials. And you know, with the results of those trials, maybe one day we'll see it more in the upfront setting. But for now, I think the majority of practitioners are using it mostly for recurrence, or in special cases like the rapid recurrence that you saw, where standard of care was for some reason technically difficult.
Okay. And what's the radiation dose compared to standard external beam radiation?
That's a little bit tricky to answer because radiation doses depend on how quickly you give the radiation over how long a time. The answer to your question is it's 60 gray at 5 millimeter depth. And you know, radiosurgery procedures is only like 20 something gray or a little bit less sometimes if it's a large volume. Glioblastoma is 60 gray, but that's given over 6 weeks. And all that kind of works out to different math. But I would say it is grossly in line with radiosurgical doses. Okay.
Would it be possible to do standard or proton radiation at some point later on in your journey if you had GammaTiles inserted?
I think it's certainly possible. If you've already had GammaTiles in the salvage setting, that implies you've had prior radiation and GammaTile. So getting a third course of radiation to the same area might be a bit tricky. Not impossible, but tricky. That said, a lot of times protons are used also for recurrence. And if the recurrence is maybe just outside where you've been previously treated and treated with GammaTile, and you really don't want to put any more dose on the area that's still doing well with the GammaTile, but there's a new spot just next to it, protons might be an excellent candidate for treating that because they're able to give dose to the new recurrent, slightly distant disease without really dosing anything on the old area. So I wouldn't say that it's impossible, but anytime you're reirradiating the same volume, it's always tricky and always kind of a longer conversation with your provider.
Okay, and this is sort of a related question. You may have sort of already answered it, but could you use GammaTiles after already receiving your, lifetime maximum dose of standard or proton radiation?
I mean, I think lifetime maximum dose is a relatively loose term.
Okay.
It depends on how long it's been since you got the radiation. If you got 60 gray last week, I'm going to balk at giving anything further. If you got 60 gray 40 years ago and now have recurrence, that's a different story. Is it pristine brain tissue? No, absolutely not. But is it different than if it were 6 weeks old? It is. So just like, what's the dose is kind of its complicated answer. The what's your maximum lifetime dose is also a very complicated type of answer. So yes, it's possible, but not always. And it's kind of depends on what it looks like, how big the recurrence is, what the prior dose was, how long it's been since then.
It depends.
Yeah, it depends. Definitely depends.
Okay. And you mentioned some of the clinical trials that you all have going on, but GammaTiles are FDA approved. So why would you want to enter the clinical trial if they're approved and easily available?
They're approved. Easily available is somewhat of a loose term as well. So again, not every center has it. Lots do, lots don't. And I think in looking to expand the indications, you want to get more robust data. We're all looking for more robust data. And even in the setting of giving standard radiation, we have ongoing clinical trials. There's clinical trials open now for giving radiation and chemotherapy for glioblastoma in terms of, can we give more dose? Can we give boosts? Can we give other chemotherapies are being looked at? So just because you're approved doesn't mean that you shouldn't continue to try to improve further. And just because you're approved doesn't mean that, just because it's allowed doesn't mean it's the best treatment in any given circumstance. And the trials are really looking to answer that. If this is effective, it's allowed. If for some reason the patient needs it in the upfront, it's FDA approved, but it's really better than standard of care in the upfront. I think that's a little more nebulous to answer.
Okay. Okay. And will having GammaTile preclude you from entering other clinical trials?
That's going to depend on the trial. Some trials require that you have, no prior treatment or no treatment within a certain time scale. So that's a possibility, but that's going to look a lot at what the trial is trying to examine. I can't think offhand of any trial that has explicitly disqualified brachytherapy patients for trial. But you might fall under some other silo of previous radiation or prior treatment within a certain time scale. But nothing specific that I can think of.
Okay. Okay. We just have a couple more. Does GammaTile work for a multifocal patient with tumors in more than one location? Can you use them in that scenario?
Sort of. These are good questions. They're all rather complicated. So the benefit of GammaTile is that it's very focused. So that limits toxicity, limits side effects, but it also means you get dose where you put it and you don't get it anywhere else. So if it's multifocal, then it's usable if you're able to do a multifocal resection. If you have two brain mets at distant areas and you resect both, you can use GammaTile in both, certainly. We in fact did that on a patient. He had two relatively large areas. They were separated in different lobes of the brain. We did two craniotomies at once, did two resections, two implants. He did well. That said, if we implanted in one location, it's going to take care of ones in other locations? Not particularly, no. There's a couple caveats in terms of immune response and other factors that are sort of a little more nebulous, but in general, no, it's not going to work for multifocal stuff unless you do resections of all the sites of disease. That said, it may be useful for the largest site, and the other sites, maybe you mop up with external beam radiation or other techniques. So it can still have utility, but it is not in itself going to treat diffuse disease. Thank
you. Yep. Okay. And is there a genomic composition that favors effectiveness? Have you done any research on that, or?
Boy, they just keep getting better. There are certain genomic profiles that have more or less radiosensitivity in terms of implanted radiation or GammaTile specifically. I don't know of any data looking at that particularly. Certainly some are more radioresistant types of pathology. But I would say once you're to the point that you need this, this is going to be as effective as a lot of your other treatment options in terms of radiation. So yes, surely some tumors will be more radiosensitive than others. That said, in the recurrent setting, a lot of these tumors have been exposed to radiation. You've selected for the cells that are already radiation resistant. So saying, oh, sure, this tumor always does well with radiation isn't necessarily true in the recurrent setting. So there will certainly be variability. I have no hard and fast answers as to which would be better or worse.
Okay. And you presented some of this, but someone asked any data in regards to overall survival and progression-free survival. So I guess, probably it's limited data at the newly diagnosed stage, but at the recurrent stage, kind of what's your general sense of?
Most of our data look at local control. That's very good. In terms of overall progression, this doesn't purport to do anything for control, outside the treated area. So I would say patients do very well in terms of local control, and beyond that, there are some reported overall survival numbers, but that's usually not the primary outcome measure. But I think that will be forthcoming with future data.
Okay. And finally, I think this is our last question. Is there a size limit to the tumor that can be treated with GammaTiles?
Not a precise one. It really depends on how many tiles you're able to implant safely. You know, after you pass a certain size, you're going to start encroaching on other anatomic structures. Once you go into the ventricles, these sort of cavities inside the brain, it's hard to hold the tiles in place. So there are some limits, but again, that's a case by case, I think, evaluation. We've gone into the teens before. I think other centers have as well. I think once you pass a certain point, you're getting into kind of what was alluded to before in terms of diffuse brain disease, and is a focal treatment really the appropriate thing? No hard and fast cutoff necessarily, but once you probably get beyond 4 or 5 centimeters, you're going to start to run into issues with technical complications with implant probably. But everybody's different.
Okay, and I was just kidding. I have one more follow-up question from the survival question. So in the trial for recurrent GBM, what was the overall survival and progression-free survival, if you recall?
I don't have those with me, so I have to defer on that one. Yeah, sorry, I can't quote those off the top of my head. I don't want to give you a wrong number.
No problem. I think that's it for questions. Thank you very much, Dr. Tatebe. This is a great presentation, and Patty, thank you for joining as well. And thanks for everyone on the call. Have a good night.
Thanks so much. Thank you, everybody.